At ASCO 2024, I was invited to be the discussant for the first myeloma session that discussed the development of new effective therapies in the newly diagnosed patient population. I was assigned the topic quadruplet therapy, the more the better, question mark. There were 3 studies that were presented. All those 3 trials used combinations of small molecules. They used proteasome inhibitors, IMiDs, and steroids. And they also used as the randomization an immunotherapy. This was CD38 targeted antibodies. There were differences across the studies. 2 of the trials used Isatuximab, CD38 targeted monoclonal antibody, and 1 of the trials included Daratumumab, also CD38 targeted monoclonal antibody. 2 of the studies used the backbone of those small molecules I mentioned, plus minus the antibody. So in one study it was plus minus Isatuximab, the other one was plus minus Daratumumab. And for 1 of the trials, it actually used the immunotherapy with the IMiD and the steroid plus minus the proteasome inhibitor. So a little bit different from what a lot of other trials have tried to do, to use the immunotherapy plus minus there. So the 4th drug was different across the trials. Also, I should emphasize and say that the indications were different, although they were all newly diagnosed patients. For 2 of the trials, they were newly diagnosed patients without the intent of going to transplantation. So they were up to 80 years of age. And for 1 of the trials, this was for patients that were transplant eligible. What was striking to me as the discussant for ASCO was that however you look at it from a transplant eligible or transplant ineligible perspective, it's obvious that adding the 4th drug will improve outcome. So I was raising the question, we are now at the point where results are so good, we are narrowing the gap between these 2 groups of patients, transplant eligible and transplant ineligible. So isn't it time to retire this 40-year-old terminology of transplant eligible and ineligible? And that was discussed during the Q&A session as well. Quadruplet therapy is changing the myeloma treatment landscape in many ways. I think it shows, as I mentioned before, that you can deepen the response, you can prolong progression-free survival, and maybe also overall survival. There are some early indications for that. And the fact that you can add an immunotherapy to existing backbones and achieve these improvements also comes with the fact that the toxicity profile is actually very limited. And that brings down the barrier between the younger, fit, previously so-called the transplant eligible, and the older patient that may be more frail, also called the transplant ineligible. So it's narrowing the gap, is removing this discrimination. Older patients in the past, more frail patients, were not able to get effective therapies because the effective therapies long time ago were chemotherapies like transplant and other more aggressive drugs. So you couldn't give them to older patients. And keep in mind that myeloma has an average age of onset of about 70 years. So half the patients would immediately fall in that category. So what we see now is that with new, modern, effective therapies that are immunotherapy-based, you can actually deliver very good outcomes to all patients independent of age or performance status, pretty much. I would say pretty much because for patients that are really frail or maybe cannot really come into the clinic, they may be older and weaker, to go that hard is probably not the right thing for every patient, but age per se should never be the discriminator to deliver effective therapy. You should always discuss goal of treatment with every patient, and we should let every patient have access to these modern drugs. So as the discussant for ASCO 2024, I was asked to go over the trials, give the high points, what my interpretation and conclusions were, and also in particular to look for patterns. I looked at patterns for study design, I looked for patterns of efficacy, also importantly patterns for safety. I pointed out that for 2 of the trials, the randomized drug between the experimental and the control arm was the immunotherapy, the CD38 targeted antibody. In those patients who got that antibody added to the backbone, you could see a little bit more of infection. But I also mentioned that none of these infections were life-threatening and they were all manageable. So you have to just be on top of it as the treating physician. For one of the trials, the drug that was randomized between the experimental and the control arm was the old proteasome inhibitor bortezomib. So all patients in that trial used an immunotherapy and an IMiD and steroid, and it was plus minus bortezomib. Bortezomib was approved back in 2003 and has a very well documented side effect profile of neuropathy. I emphasize the fact that a lot of the neuropathy are what's called grade 2. And for most trials, when we do cancer drug development, we look for grade 3 or higher. But for some side effects, even a grade 2 toxicity can be quite negative for the patient. And that is true for the peripheral neuropathy. Peripheral neuropathy grade 2 severely interferes with the patient's active daily living activities, or the ADLs. And almost 50% of the patients had that. So I think that's an important consideration to think about adding the fourth drug. Lastly, as the discussant for ASCO, I was asked to address other studies that have tried to look into this and overcome. And I mentioned that the German group, the GMMG concept trial, and also American studies such as the Manhattan trial has used carfilzomib instead of bortezomib to avoid the bortezomib-induced peripheral neuropathy. And those are examples of trials that partner both with Daratumumab and Isatuximab respectively. And I also mentioned that there are other trials ongoing using bispecific antibodies. I did not show any results because they have not yet been published, but I mentioned them to just educate the audience. So a lot of improvements are ongoing, and we hope that we will continue to improve the field that way. So as I mentioned multiple times, the efficacy was superior for the 4 versus the 3 drugs if you look overall. So if you have 100 patients treated with a 4 drug and 100 patients treated with a 3 drug, in those 100 patients treated with the 4 drugs, there are more deep responses, there is longer progression-free survival, and there is an indication that maybe even overall survival is better. But as always, the devil is in the details. So we look a little bit at some stratifications. So that means if you look at those trials and randomize between 4 versus 3 drugs, there are patients that actually have a deep response with 3 drugs. And if you look at those who have MRD negativity with 4 drugs compared to those that are MRD negative with 3 drugs, they seem to have very similar, if not the same, progression-free survival and probably also overall survival. So why is that? Well, myeloma is a complicated disease. It's not the same disease in every patient. Life is not fair. So some patients can get a very good response to less therapy. At the same time, if you look at those trials that use 4 versus 3 drugs, there are more patients having MRD negativity with 4 drugs than there are with 3 drugs. So if you don't have the ability to test for MRD negativity, you probably should give it to every patient, or you could argue that. But you could also think about other approaches, and I try to address this as a future direction, saying, could you have a response-adapted approach in your clinic? Could you think of maybe giving every patient all the drugs, all the 4 drugs, and if you reach the goal, could you potentially step back? Or could you give fewer drugs? Could you give 3 drugs, and if you don't reach the response at a certain time, you add in the 4th drug? Or do you just give all the 4 drugs to all the patients from the beginning and all the way through? And I said these are questions where we really need to do more studies trying to understand better how this works. And I think studies would include biological profiling of the disease, the immune system, also taking into account the treatment and see how the outcomes go. The very last thing I mentioned here was that this is really what the so-called precision medicine is all about, to better tailor therapy for individual patients, to optimize outcomes, to avoid over and under treatment. And I also think that precision medicine is the only way forward for us in the end to get at what this high-risk disease category is all about. More and more patients benefit from great new therapies, but there is still a group of patients that don't do that. How are they different? What's their biology? How will we be able to dissect that and overcome and deliver good outcome for every patient, including those high-risk disease patients? That's where precision medicine is very important. Only way forward.